The last thing I'm going to say is that Georgia is going to present next month. We usually meet on the 8th, but I was told we may not have the room on the 8th next month, so I'll find out this week if we have it or not. Then we have it on another day. But Georgia's going to walk us through the various strategies for moving forward in California, whether it be legislation or referendums, financial analysis, all the things necessary for the 2017 waiver. And so she's going to tell us where the light at the end of the tunnel is, or the many lights at the end of the many tunnels that we're going to have to go through. So she's going to present next month. I'm hoping it's the 8th here, but we'll find out. Nancy's been researching the Affordable Care Act because in PNHP and in HCA and all these different groups, we all know a lot about single payer, but nobody's asking us about single payer. We're asking about the Affordable Care Act. So Nancy's one of the brave souls who decided to try to make sense of a 2,700-page document that has over 20,000 pages of regulations and counting. They're tweaking it all the time and granting waivers and altering things and changing things, and she's keeping on top of it. And so she's kind of the go-to person for the ACA, for the rest of us that really want to know stuff, because she's spent so much time researching it and putting it together. And she's done ground rounds, and she's going to do a presentation this Saturday as well. I'll give you a little bit of Nancy's background. She's a graduate of Radcliffe College. She attended medical school at Yale and Einstein College of Medicine. She did a residency in internal medicine at University of California, Irvine, and obviously stayed, and a fellowship in endocrinology and gynecologic endocrinology at USC. She was a staff internist at Kaiser for 5 years and then taught clinical medicine at the University of California for 15 years. While she was there, she supervised a curriculum in women's health. She was a co-investigator of the Women's Health Initiative and served as the medical director for a community clinic serving mostly indigent patients. More recently, Dr. Greep has worked at the John Wayne Cancer Institute, where she has supervised a program in bone densitometry and participated in research related to vitamin D and breast cancer. She has a long-standing interest in women's health, especially hormone replacement therapy. I think we're all going to come after you at the end with our questions, all of us women. So anyway, a strong, long-standing interest in women's health, especially hormone replacement therapy and health policy, specifically strategies to achieve universal health care. So let's give a warm welcome to Nancy Greep. And she's a mother and a grandmother and a tennis player.
Yes, and I play tennis with her.
Oh, I didn't know that. Okay.
Well, thank you. It's pretty clear that, I'm going to be talking to the choir here, but I guess that's okay. It's kind of practice and we can all inform ourselves. I think you hit the nail on the head, which is that we're trying to get invitations to speak to physician groups in grand rounds, and they're not interested in single payer. They're interested in the Affordable Care Act, so that's where the calls are coming from. So it's sort of a stealth for me, stealth bomber going in there. I come in talking about the Affordable Care Act, and then at the very end I come in and say there's a better way. Anyway, so you're welcome to ask questions. I just want to warn you up front that this is about an hour. So if there's a lot of questions going on, we'll be here all night. Okay. So I'm going to very briefly review the need for health reform, and then review the provisions of the ACA, and then critique it. So we all know that we got a problem with access with uninsured and underinsured people, that our health system costs twice as much or 2.5 times as much as it costs anywhere else in the world, and that we don't have great health outcomes, and that people who are not insured or underinsured also don't have great outcomes. And that we also have a multi-tiered system where those who are more wealthy get better care than those who are not so well off. So, on to the Affordable Care Act, or Obamacare. As Maureen mentioned, I did not read the act, I will have to confess. I tried. Actually, it's impossible to read the thing if you read legal documents. But anyway, and I bet you a lot of our legislators didn't read it either.
No,
Had
actually, the
their-
quip
had their
was,
aides read it, I think. But
well, the quip was, now that it's passed, maybe we'll find out what's in it. That's what I believe Henry Wax said.
anyway, it is, it's more than 2,000 pages. The regulations several months ago were 20,000 pages, and it is growing. It's just a massive monstrosity. So this was kind of the thinking behind the Affordable Care Act. It's not my thinking, but it was the thinking of the government, I think, on how to approach this healthcare crisis that we had. So they figured that a lot of the problem was the fee-for-service, and this meant that people were getting excess unnecessary care, maybe up to 30% of care was really unnecessary. So in order to move away from fee-for-service, they want to move towards more of a capitated system where you need to consolidate and be big enough so that an organization can accept the risk. But then when you get into that, you're get into the problem of your might be tempted to deny care, so then you try to protect the patients by having paid for performance to protect the patients. And then because the insurance premiums were high, I thought this was because maybe it's not enough competition in the insurance market, so they wanted to increase competition through the market and exchange. They recognize that actually our healthcare system is very fragmented and our primary care is lacking, and it's uncoordinated care. I think as physicians that we are kind of responsible for that. It's a big problem. So they wanted to encourage primary care and patient-centered care, and we'll be talking about the accountable care organizations. Then they felt there was this moral hazard problem. This refers to the fact that people who are insured, they feel kind of entitled to be more risky because they figure they're going to be covered, and so they may seek more care. So part of this was to increase the patient share of cost. They recognize that uninsured people are sicker and costlier, so they wanted to expand access, fraud and abuse, more policing, and guess what? Some of this transparency you're hearing about today in the newspaper actually comes from the Affordable Care Act. And I don't know why we didn't have it before, but we should have. So that's actually a good thing that's come out of the Affordable Care Act. And then defensive medicine, theoretically, they should have had tort reform. It's minimal in the Affordable Care Act. And then, this critical issue of we need to control prices. They always said, it's the price is stupid. That's why our system is so expensive. There's not a whole lot in there that controls the prices. But anyway. So in terms of increasing access, before we get to that, I just wanted to remind you what the insurance status is of Americans. This is from 2012, and it mostly represents what the insurance status of Americans was before the Affordable Care Act really kicked in 2004. So you can read the numbers, but the little arrows indicate the fact that most of the Affordable Care Act was directed at people who had individual policies or who were excluded from individual policies, or the uninsured. And clearly that's the minority of people in the country, but that's basically what the Affordable Care Act, a lot of it was all about. So, and then just to mention, I'm going to give you a table of comparison of what the health insurance reforms was, but there is the plans, if they formed before 2010 when the law was passed, and they haven't changed any of the structure of their plans, that is, they haven't changed the co-pays, the deductibles, and the stuff like that, they could continue as a grandfathered plan and not be subject to the regulations of the Affordable Care Act. They could raise the premiums, however, and that didn't make them lose their grandfather status. But it turns out they're always monkeying with the structure of these plans, and so it's predicted that, in a short period of time, there really aren't going to be too many of these grandfathered plans left. But anyway, so I think there are about 3 slides like this that are reforms to the private health insurance. So the first one is that dependents at less than 26 could stay on their parents' plans. Everything on this page affected all insurance, and whether it was insurance obtained through the individual or small group market or through an employer-provided insurance. So then there was the minimal medical loss ratio, where the insurance companies had to spend at least 80%, if not 85%, of their premium dollar on health care, and if they didn't, they had to reimburse people. And that's already happened. could have no waiting periods more than 90 days, you couldn't rescind a policy except for frank fraud, and they had to provide standardized summary of benefits and coverage so that people have some idea of what they're getting. Then they eliminated annual and lifetime limits, thank goodness. And then very importantly, they eliminated the exclusion of pre-existing illness. So that's, you know, where the individual comes in, because group plans, it doesn't matter, you're not rated on your health. It's just if you work for somebody, you're included in the plan. But the individual, they were looking at your age and your health and so forth and rating you, and even deciding whether they wanted to insure you at all. So they can't do that anymore in terms of excluding you. Then they divided these plans up. They felt that it would be easier for people to understand them, but as we just heard, even though they tried to make it easier to understand, it's still a nightmare. But anyway, into the bronze, silver, gold, and platinums, which is a 60% actuarial value, and this is a 90% actuarial value. And they also, this was good, they didn't require prior authorization to go to an emergency room, and that you couldn't have more increased cost sharing if you were in an emergency room, because you're taken there by ambulance or paramedics, and you don't really have a choice about where you're going. Then they increased the scope of service. This was one of the reasons why there was so much hullabaloo in the paper about people who were losing their plans and being replaced by much more expensive plans. You used to have these plans which were junk plans. They hardly covered anything, but they were cheap. Well, they wanted to get rid of that, and so they created that you had to have 10 essential benefits, which I'll mention briefly, but everything you could imagine it should be covered: physician visits, surgery, drugs, etc. And then also to try to get at the health of the population, no cost for certain preventive services. This is a little tricky because, first of all, it's not just any preventive service. It has to be a preventive service that they okay. And furthermore, it's, for example, you got to be careful, because this is why the devil is in the details. Because, for example, for a colonoscopy, if you have it in a hospital, you may have anesthesia and you have a hospital fee, so they may not charge you for the colonoscopy, but you're going to get a bill from the anesthesiologist, and you're going to get a bill from the hospital for using the hospital. It's not free. So it's kind of misleading. But this is very important, that there's a maximum out-of-pocket expense. We were concerned about our uninsurance and even our insured people who were going into medical bankruptcy, because, you know, if they got really sick and even were sharing a modest portion of their health care costs, if they had a humongous hospital bill, that still was a lot of money. So this is really going to help, that the most one is expected to spend out of pocket for an individual is this amount, and for a family this amount. One little trick, though, is that is only for care that's covered by the plan and is in-network. If it's out of network, or if you go to a birthing center and the center doesn't cover birthing centers, that doesn't count. So you gotta watch out. And then no referral needed for OBGYN. Oh, and Maureen and I struggled so much about this, is that for the individual group is the one where I'm going to mention them again, is the 10 so-called essential benefits. And curiously, it's not required of the employer-sponsored group, and I just kept figuring, why is that? Because most people are getting their insurance from their employer. What's going on? It turns out I didn't realize, but it's at the state level. The state controls what employers can offer their employees, and they've already got that base covered pretty much. They can't offer them junk plans. So I talked to somebody in the insurance area. So this is the essential health benefits package, the things that you would expect. Now, one problem is that it just tells you the scope of coverage, but it doesn't tell you the details. And we were hoping a couple of years ago, the Institute of Medicine tried to come up with a definition of what these plans must include, and we were hoping it would be all medically necessary care. They came to the conclusion we can't do that because we have to take affordability into account. So unfortunately, it's, instead of all necessary care, it's more or less what's reasonably affordable care. And to decide what's reasonably affordable, each state gets to choose from a bunch of benchmark plans, their benchmark. And in California chose the Kaiser Small Group HMO. That's our benchmark plan. So the kind of benefits that that plan has is what the plans in exchange have to mirror. This may be, for example, telling you how many rehabilitative, how many physical therapy appointments you can have, and that kind of detail. Yes, you have to provide physical therapy, but you know, they could say little or a lot, so that's how it's sort of set up. So here are more now reforms to private insurance. So in terms of trying to control costs, they have this very weak regulation in here, which is that if an insurance company raises their rate more than 10%, then that's sent to the attention of the state insurance commissioner. But he has no power to override it. And that's also true in California, although there's a bill that will probably be presented in the fall that attempts to give our insurance commissioner the right to not let them do that. And then this is very important, that there's no rating by individual health or gender. Women were always discriminated against because we had babies. And you know, you saw in the paper, men were furious. Why should I have to cover somebody having a baby? You know, they didn't get the picture that, you know, we're trying to cover the population health.
And they have something to do with it.
Yeah, exactly. And the other thing is that they can only rate you by your age on a 3-to-1 factor. Now, historically, what they would do is rate you about 6 or 5 to 1, so that the older person's insurance would cost 6 times what the younger person's insurance was. They've limited that now. The older person can only be charged 3 times as much as the younger person. Therefore, the younger person is going to wind up paying more, and the older person is going to wind up paying a little less, just on age alone. And then important family size, and then geography. It turns out, you know, they get to rate, they get to set their premiums according to specific geographic regions. So even within California, adjacent regions can have widely different premiums. And in different states, it's widely different premiums. I don't know why California decided not to include smoking, but they did. And then guaranteed issue, and then right to an internal and external review. So, as I said, one consequence of healthcare reform is if you like your policy, you may not be able to keep it. That's because they got rid of the bare bones policies that were cheap in the past, and because now there's an age rating change, so that the younger folks now have to pay more. So, sounds great, but what's the problem with this? Well, in the first place, it leaves in place the administrative complexity associated with multiple insurers. Most of the insurance plans remain for-profit, which I think we all agree is kind of an oxymoron, because how do you make a profit but charge more and withhold care? There's a lot of other problems with it, but I won't go into that. You're all aware of that. And then, unfortunately, it also, as was mentioned, it enshrines underinsurance as the norm, because it turns out if people are offered different plans costing from covering 60% to 90% of actuarial value, and the 60% are cheap and the 90% are expensive, they'll go for the 60%. Now remember that group insurance, typical through an employer, is typically 85% coverage. So now with these, now they're saying, well, all you have to do is to provide 60%. So now there's going to be probably a move to the lowest common denominator. And then the other problem is, of course, is that there's lots of people who remain uninsured, we'll go over that in a minute, or underinsured. As I said, so many of these people are picking policies that are their coverage is actually pretty poor in dollar amounts. We went over this, and then there's no real control over the cost of premiums or prices. This is one of the lines of people trying to sign up for the exchanges. Well, clearly there is a social interest in this. People were hurting and were desperate. And the fact that we have these lines to sign up for this junk indicates that, you know, there was a big need out of there. So let's go over the exchanges. What are they? Well, they're open only to individuals and small business. It pools the risk of the healthy and sick, and the sick in the individual and small group market. Now, if individuals are offered affordable, adequate, meaning it covers 60% of actuarial costs through their insurer, they can buy on the exchange, but they're not eligible for subsidies. So since the plans that are on the exchange, as it turns out, are not nearly as generous as those of the employer, there's probably not too many people who are getting employer-provided insurance who are going to jump over to the exchange. And then the exchanges, as you know, are state-based, and they can either run their own exchange, which is California has decided to do, or defer to let the federal government run it. And of course, the problem is that when they passed the law, they thought all the states would want to run their own exchange. Well, we have this problem that 26 of the states didn't want to have anything to do with this thing, so they decided to let the federal government run their exchange, and couldn't handle it. It was just too much. They couldn't handle all 27 or 6 states not having their own exchange. And one tricky thing is that only the states who decided to run their own exchanges were the ones who got federal money to run their exchange. And California, as somebody mentioned, got a ton of money. And it takes a lot of money to get the thing running. And for the outreach effort, as was explained before, it takes a lot of money to reach out. And then in California, we have the different insurers had to kind of apply to be part of the exchange, and they had to demonstrate that they had adequate numbers of doctors and hospitals in their network, and a variety of things. And then the state reviewed those and decided which insurers could participate. In California, we have 11 insurers.
Out of how many?
How many insurers
applied originally and only?
I don't know. And I actually tried to look up how many insurers, health insurers there are in the United States. You know, I couldn't come up with a number. I started looking. I could get numbers for insurance companies, but not. Anyway, I know there are millions of plans, but how many of them are actual insured, I'm not sure. And then, you know about the open enrollment, but in future years, it's going to be a much narrower window for enrollment.
Nancy, in that 11 insurers, in each area that
I'll come to that.
Oh, okay, all right.
So there are, as I mentioned, the standardized levels of coverage. And for the under 30, there is this catastrophic plan. And curiously, the insurance companies have to offer identical plans in and out of the exchange. But of course, you know, outside of the exchange, you're not eligible for subsidy. So I think this is just people who don't want to be tainted with having to go through the Covered California portal. Anyway, they have to publicize their ratings eventually on quality, price, and customer satisfaction. This is their aim to try to increase so-called competition. And unfortunately, it's not open to the undocumented, which is really tragic, even if they were willing to pay for it. That's just mean. And then they have all the plans have to have a standardized presentation and application form. And importantly, there's no asset information required. You just have to provide income. In the past, when patients went to sign up for Medicaid, they had to provide evidence of, you know, their utility bills, whether they had a car or a house and all that. It was very complicated. Now they just want to know what your income was. And then there's no wrong door policy, that if you went into the one of these enrollment counselors, if it turned out you were eligible for Medicaid, they sign you up for Medicaid. If it turns out you made too much to be in Medicaid, they'll sign you up for the exchange.
I wanted to ask about the word actuarial value.
Yeah.
When they talk about 60%, that means that you as an individual would pay 40%? And is that based on total out-of-pocket cost?
Yes, that is exactly. No, what it's based on is there are these standard calculations of how much an individual's health care is going to cost. I don't know what the details are, but these insurance companies, I'm sure, have got it down to a fine art of how much cost they can expect for an individual with certain characteristics. So that's And then the plan has to be designed with deductibles and copays such that it probably is going to cover 60% of those costs.
Yeah.
It's a guess.
I was hoping that they'd use a system of total out-of-pocket costs, which they could also estimate if they wanted.
Well, they put a limit on total out-of-pocket costs. Okay, so then these are the subsidies that you've heard about. The premium they're given a subsidy so that the premium wouldn't cost more than a certain percent of the family income, at the low end 2% and at the high end 9.5%, and then after that there's no subsidy available. Once they calculate the amount of subsidy, which is based on the second least expensive silver plan, that's a dollar amount, then the individual could take that dollar amount and apply it to a platinum plan if they want, but they're going to wind up paying more, or they could even apply it to a bronze plan, in which case they pay less. And then the other thing is that this subsidy can all be taken up front, or they can take it every month. Now, the disadvantage of taking it all up front is that your income may change during the year. This thing is so ridiculously complicated. So if your income goes up during the year, then all of a sudden you're not eligible for the subsidy anymore. So when tax time comes, you got to pay it back. And you've paid it all up front. At tax time, you may have another $5,000 you got to pay back. So it's kind of recommended that you don't do that, but I mean, that's the system. And then for very low income, under 50%, there's also subsidies for cost sharing, which I won't go into. So here are the state exchanges. The federal one is healthcare.gov, and the California one is Covered California. This is one of the ads for the Covered California. These are the health plans that decided to participate in California. Let's look at this. There are 19 pricing regions in California, and not all the plans are available in all the regions. And I went through them, and there's either only three in some pricing regions, which means there's not a whole lot of competition, up to a maximum of 6. And Los Angeles is the area that has 6 plans that are participating, so it's not all 11. But some of them, it's inappropriate, like the Chinese, which is directed at the San Francisco population or something. But on a statewide basis, there are some states that have only one insurer on the exchange. What kind of competition is that? You know. Anyway, so I'm not going to read this, but why don't you just look it over, because I think you will see this is the 60%, this is the 90%. And just get a look at what the copays are across. And then the next slide will be more expensive things. I think they're going to have some sticker shock when they finally go to the doctor. And then it doesn't show up very well, but this is supposed to be a different color. And in this case, those copays and things, that doesn't contribute to their out-of-pocket expense until they've met their deductible, so it's very tricky. Here is more expensive things, like look at this. High cost and infrequent searches like hospital care and outpatient. Can you imagine paying 30% of your hospital cost? I mean, a hip replacement or whatever is probably going to be, I don't know, 40,000 some plus dollars. I had shoulder, that was 30,000. And you have to pay 30% of that? I mean, it's ridiculous. It's basically not insurance. Look at this, the imaging. I've had a whole bunch of these, and the last one I had was a couple $1,000s. I'd have to pay 30% of that? So I just pretended that I was came from a healthy family of 4 with these characteristics, and that I was trying to buy a silver plan. And I went on there and found out what it would cost me. And so I pretended that I had an annual income of $25,000, $50,000, or $100,000. This is under the federal poverty level, so this person would qualify for Medicaid, would not qualify for the exchange. This is about the median family income in the United States. Surprisingly, it's only about roughly twice the federal poverty level. It's pretty amazing, actually. And the lowest one in this plan was a HealthNet HMO. The premium was $2,700 per year. The most expensive, Kaiser was always the most expensive. was $5,712 a year. The deductible, in the less, people with less income, their deductible can be a little bit less. So this would be the deductible, and then also the maximum out-of-pocket expense. I may have written these figures down, but it's actually a little bit lower for people in lower income. So if you calculate what would the premium be as a percent of income, if this person wasn't subsidized, it would have been 11% of their income. But they're subsidized, so now it comes down to about 6% of their income. But this person is over 400% of the federal poverty level, so they don't get any subsidies. So look at this. This is what their premium, not health care, premium is as a percent of their income on the lowest cost to the highest cost plan. Now, if that's the premium, if they have to spend all of their out-of-pocket expenses before they reach that maximum, so you put the maximum out-of-pocket expense in there, you combine this with the premium, this is the percent of their income. That's the, I mean, that is really not insurance. And that's what we've created for people. And just to put this in perspective, how much do we usually spend on health care? Well, on average, about 5%. So those percentages up there in, 20% are ridiculous. This is the exchange, as you can imagine. Here are our enrollment. Oh no, here is our navigators over here that you were talking about. They enroll people. They've got to communicate with the Medicaid system. They've got to communicate with the insurance people. They've got to communicate with the feds because of income tax, et cetera. So needless to say, this is an incredibly complicated system. And guess what? It didn't work. The healthcare.gov didn't work. Big surprise.
And Nancy, those navigators, those enrollees get 2 days of training. And they're just people from the community.
I know. Actually, I tried to sign up, but that's another story. And then, as we mentioned, there's these cultural barriers to enrollment. Language. A lot of people don't read. They can't read this stuff. They don't have access to computers. And then health insurance jargon. The CPAs did a survey of Americans. Only 51% of people don't even understand at least one of these terms. So how are you going to have them choose a health plan? It's not realistic. And then the other thing is really frustrating. If you wanted to go on the insurance and find out, well, I want to choose a plan that covers Cedars-Sinai, lots of luck, Cedars-Sinai or this particular doctor, how do I know what plan to draw? Well, the directories were such a mess that they took them off of the exchange. So I went on there trying to figure it out, and the only way you could figure it out is to call the insurance company, and I spent a half hour on the line with Blue Shield trying to, pretend. Got nowhere. I was giving a talk at St. Vincent's Hospital, so I called St. Vincent's. I figured I better find out what's going on down there. So I called their insurance part. They couldn't tell me either. That's it. I've done my share. Theoretically, you're supposed to have directories, but unfortunately, the directories are only available to you if you are actually applying for insurance. So I had to pretend that I was applying, and now I'm getting letters from California saying you've got to sign up by April 15th because I couldn't get the directories otherwise. Anyway, also the networks, as you've heard, are very narrow. Some of them are extremely narrow. They may exclude up to 70% of providers who are otherwise in a fuller network for routine commercial insurance. So, and they're unstable, as was already mentioned. Insurers can decide to come and go. So you may sign up for something today and it's gone tomorrow. And the other thing is that, people were signing up for the Platinum where it's supposed to cover 90% of your costs. They figured, well, I'm paying a lot more money. I'm going to be able to go wherever I want. It's the same narrow network. The only difference is they pay more of the deductible, pays are lower, etc. But it's not, by and large, a broader network. So it doesn't include the fancy hospitals that you were hoping it was, even though you paid more for it. So, more problems with the exchange. And we've already, a lot of this has already been alluded to in the introduction, that the hospital may become contracted with Plan A, but the doctors who operate there aren't. So then what do you do? And then, as was mentioned, it's very difficult to compare these plans, even though they're standardized, because there's 6 plans and 4 different levels of coverage, and it's very difficult. And then, as I mentioned, only in-network care or covered care counts towards your deductible or maximum out-of-pocket expense. And then the concern is if too few young or healthy people sign up for the exchange, the premiums will increase next year because the insurers have just guessed what these people on the exchange are going to cost them because they don't have any prior experience. They're assuming there'll be sicker patients, and that's what the data is beginning to show. I was just reading before I came over here that compared to the normal population, there's about 4 times as many people on HIV drugs and on hepatitis C drugs. So they're picking up a sicker population. And then, of course, I mentioned the number of insurers varies by state. And then you have this problem because people's income changes during the year. Half of the year they could be on Medicaid and they go to this doctor, and then all of a sudden they're eligible for the exchange, and now they got to change and go to that doctor, and then it goes down again. It's, not smooth, and people are having to change doctors and start all over. Now, what about the individual mandate? After 2014, you're well aware, everyone must have so-called qualifying health insurance. That is, it has to cover at least 60% of your expected costs, or you pay a penalty. Now, there are certain exemptions. I won't read them, and including a whole bunch of hardships ones, which I'll just show briefly. The penalty is phased in.
In prison. That's interesting.
Yeah, the penalty is phased in, but somebody told me they're very busy signing the prisoners up for Medicaid, Medi-Cal. Although they can't use it, as soon as they get out of prison, they want them to be on Medicaid.
Oh,
Right,
that's good.
that's been a boon.
Yeah, that's good. So the penalty is phased in, and so by 2016, it's $695 per person, or whichever is greater. And for most people, it'll be this one, the 2.5% of taxable income, which is above the filing threshold, which is about $10,000 for an individual and $20,000 for a family or a couple. And so that's probably going to be the more expensive one. That's going to be really, people are going to learn the hard way. They think they're only going to pay that, and they're going to pay a lot more. And it's at tax time, so you can't really evade it. But then again, we heard so much about this individual mandate. This is what the Republicans were going crazy over. We're talking about 7% of the population here as being affected by that, because everybody else either has insurance or is not eligible for insurance. I won't read these. There's a whole bunch of hardship exemptions, so I can imagine there's going to be a lot of gamesmanship going on and people who don't want to pay their penalties. Now, expanding Medicaid, as you know, it used to be only available to certain categories of individuals, and the average poor adult was not eligible for Medicaid. So that was a serious problem when I was at that clinic, when we were treating mostly indigent adults, and they weren't eligible for Medicaid. So it was very hard to teach there and very hard to provide care because they didn't have any kind of insurance. And the other thing is that the threshold for Medicaid varies dramatically across the United States. In the southern states, it's really low. I mean, if the federal poverty level is like $10,000, and they only cover it if you're below 23% of that, in other words, if you only make a couple $1,000
Wow.
a year, it's shocking.
Yeah.
So, and that'll come up later. So this is good, that the Affordable Care Act now is extending Medicaid to childless adults up to 133% of the federal poverty level, but there's a fudge factor of 5%, so you may hear the figure 138% as well. Well, as you know, the state participation is voluntary after the Supreme Court ruling, so 26 states have refused to expand their Medicaid. This is just a reminder what the federal poverty level is. and what the cutoff would be for the Medicaid. These are the states that will expand in yellow, and these are the ones that are not, southern and middle of the country. Well, the problem with this is that we have what's called a gap. We have these individuals, like say we're living in a southern state where the eligibility for Medicaid is 23% or something. Well, you, in order to be eligible for a subsidy, you have to be between 100% and 400% of the federal poverty level. Well, if you're under 100%, but more than the threshold for the Medicaid, you're eligible for nothing.
Oh, my God.
They figured that all the states would come on board, and there's no reason they should, because they're planning to pay, the feds are planning to pay 90% of the costs of the Medicaid expansion, and 100% for the first 3 years, so there's very little excuse for them not expanding. So here's the problem. As a result of this coverage graph, that will lead to 4.2 million people in these 26 states that will be missed, and they're all poor, or in some very poor, and they're typically a high proportion of ethnic minorities. And because of that, uninsurance is associated with death, and we can project that about 7,000 people will die because these governors decided not to expand Medicaid. And it is amazing that we haven't heard that much outcry from the public about, why aren't you expanding Medicaid? I haven't heard a whole lot about it, but it may be because the media is not covering it, because there are people out there protesting. They should be. There's no good excuse for them not to expand. I'm not going the wrong way. Okay. So then they also wanted to increase primary care providers. I won't go into the details, but they have a whole funding programs, incentive programs to try to encourage people to go into primary care, because it was recognized that we're short on primary care doctors. We only have about 30% of our healthcare workforce is primary care, and the other 70%, which makes more money, is specialty. So what about the employer mandate? If you have more than 50 employees, if you don't have more than 50 employees, you're not subject to the penalties, but you could be eligible for some tax credits if you decide to buy insurance for your employees. But if you are more than 50 employees, then you've got to provide insurance or pay a penalty. You have to provide insurance to more than 95% of your employees, but this is all the backpedaling that's going on, because just, I don't remember what month, a couple months ago, he went back to 70% because the employers were yelling about it. So if you don't, then you pay a penalty. It's like $2,000 per employee, minus the first 30. Well, supposing you provide insurance, well, your insurance has to be both quality and affordable. So by quality, they mean it has to cover 60% of the actuarial costs, and it has to cost the worker, for an individual, for a plan for him or herself, less than the worker's income. Now, of course, the problem is most workers have families, and they want to buy family policies, which are much more expensive than individual policies. And what makes this even worse is if they can't afford the family policy, and they have a wife or children now who are uninsured, when those individuals go to the exchange to buy insurance, by definition, they are not eligible for subsidies because they have an employee who has affordable, adequate insurance. Oh my God is right. And the other thing that's tricky about this is the employer only has to pay the penalty, not if somebody goes to the exchange, but if they get subsidized on the exchange. So, it's
Say that
like
again.
Walmart,
What did you say just now?
that they only penalized if more than one or more workers is subsidized on the exchange. Not that they buy on the exchange, is subsidized on the exchange.
They get penalized if somebody's subsidized.
Correct. It's a way to try to pay for the subsidies. Okay. And then there's the so-called Walmart loophole, which is if you pay your employees so little that they're eligible for Medicaid, now they're covered, and so you don't get penalized because they're covered by Medicaid.
Oh, wonderful.
Where which pays all the general public pays for the health insurance of these giant corporations. So this is the projected effect of the Affordable Care Act on insurance status. This is without it, and this is with it. What you can see is that basically most people are continue to have private insurance. What the main thing that's going to happen is just going to be some more people now on Medicaid. Medicare doesn't change, and the uninsured goes down from about 18% to 10%. Gets cut roughly in half, but by certainly not all the way down. And the exchanges make up the difference here. Okay. So who are the uninsured after the Affordable Care is implemented? Some people think, oh, well, it's not a problem because it's all undocumented immigrants. It's not. Yes, about a quarter of them are undocumented immigrants, and they're uninsured partly of our own fault because we wouldn't let them buy it. But then they're thinking that there are certain people who are just going to try to skirt the mandate. And then another problem is again, you alluded to this, is that there's a lot of patients out there that are eligible for Medicaid, but they're immigrants, they don't speak English, they have no idea what the Medicaid program is. It's very hard to reach them. So they're potentially eligible, but having to reach out to them is very difficult. So controlling cost. This is just an overview of the costs and expenses. And obviously this program is going to cost money because the feds are putting in money for the Medicaid expansion, for the exchange subsidies, tax credits for small employers. So that amounts to about $1.5 trillion. And then how are they going to pay for this? Well, they're hoping to pay for it through these penalties, some excise tax and other taxes, which I'll show you briefly. But still, even so, after all of that, it's a net cost of $1 trillion. So it's a very expensive. I'll just let you look at this. These are some of the taxes that they're using to try to pay for this. One that you've heard about already in this meeting is the reinsurance tax, where they're going to tax medical devices, pharmaceuticals, insurance plans. And so the Taft-Hartley plans, we had that talk before, that they're very mad because they're not eligible for the subsidies on the exchange, and yet they have to pay $64 per person per year of a tax. And the purpose of this is to prevent the health insurance companies from losing money.
Yeah.
Anyway, so most cost controls are really quite dubious. I won't belabor it, but they were hoping that, well, just let's take a couple of them. You know, prevention wellness, it sounds great, but guess what? It costs money to provide well care. It costs money to give mammograms. It costs money to do colonoscopies. So this idea that somehow or other we're going to have a healthier population that's going to cost less, it doesn't pan out. Similarly, electronic medical records, they're very expensive, and they don't talk to each other, and they slow doctors down. So they're not saving money by any means. And then, of course, we have no real price controls on insurance premiums or the cost of care. Well, this is just, I'm so glad I'm retired. This is the physician quality reporting system. This is what doctors are now going to have to do when they submit a bill to the insurance companies who are going to be following their quality of care. So you have to go through all of these machinations to submit your bill and try to determine whether it was appropriate care and whatnot. This is just a slide showing, well, how much of an impact is the Affordable Care Act going to have on our national health expenditures? Almost none. This is actually the projection. Here's in yellow is the projection without the reform over time. And then two different independent projections, including from the federal government, on what what costs are going to be over time. And they're basically the same. So quality, they have in place a whole bunch of programs to try to improve quality. I'll be talking a lot more about this on the Saturday meeting because the accountable care organizations are going to affect doctors. But basically the idea is it's basically kind of pay for performance kind of stuff that's going on. So how does it measure up? Well, it does prevent some of the major abuses of the private health insurance industry, particularly no exclusion for pre-existing illness, no rating on health, age, or gender, no annual or lifetime limits, restrains rescission, it limits. Some insurance companies were only spending 70% of the healthcare dollar on care. Now they can't do that anymore. And it requires a broader scope of services in the plans. And yes, it does increase insurance to millions, both through the exchange, another 7 million here, expansion of Medicaid, another 4 million nationally, and allowing dependents to stay on their parents' plans. That's another 3 million people. And now that employers are supposedly supposed to provide your health insurance, there probably would be less job law. And as I mentioned, there's probably less fear of medical bankruptcy now, although for the low-income people, the maximum costs are still high. But big expenses have been constrained. And I think they recognize that there is a need for better coordinated care. And that ideally, yeah, we would have good electronic health records. Theoretically, it makes a lot of sense. And there's some attempt to control cost, but it's minimal. So the limitations of the Affordable Care Act, I don't need to tell this audience, but it leaves the for-profit insurance industry intact, and they're part of the problem, not the solution, and it's administratively very complex. And it leaves insurance tied to employment, which of course makes no sense, because why should it be tied to your employment if you don't work? Too bad. And it leaves many uninsured or underinsured, and most of those who are uninsured are still citizens. And then this churning problem that I talked about, that you can't stay on the same plan. Personal health costs will remain high. They're high. Very weak cost controls, and it's costing the federal government over $1 trillion to put this program into effect. And the quality of care, it really is employing strategies. It's a whole other talk, but we're very limited or untested success. And unfortunately, it just still winds up being a very inequitable system, because the patients who get insurance through Medicaid or through the exchange is going to pay doctors 30% less. Medicaid pays them about 40% less than what they would expect from a commercial insurance. So the doctors aren't going to take the insurance. So, so people who have better insurance will go to the better places. I didn't go into it, but because I have to talk to the group on Saturday, when you think about it, doctors were really annoyed with the healthcare system, but these are their concerns. Declining reimbursement, pale, excessive regulation, bureaucracy, declining clinical autonomy when you've got to get prior authorization for everything, narrow networks, doctors, half the time they don't even know if they're on or off the network. Yeah. Cumbersome electronic health records, people sitting at the computer and not talking to the patients anymore. Malpractice is a big concern, and it really wasn't addressed in any meaningful way. And then, the consolidation that's going on. Hospitals buying up doctors' practices, retail clinics are showing up in the pharmacies, and a decreased bargaining power of independent doctors, and basically doctors don't have any political power. The AMA, if anything, they were helping us along.
Can you read that?
So not only did the Affordable Care Act not eliminate private insurance, it protected them against.
Oh, I can't read the cartoons.
Oh,
What is
the
the
joke?
cartoon?
If you look closely at your health system, you can see a slight obstruction.
That's very
Insurance industry. I won't go into the detail, but they're the so-called 3 Rs are the mechanisms by which they set in place to try to protect insurers who were going onto this exchange, which was a new adventure, and they didn't really know what kind of patients they were going to get. from losing money, and you and I are paying for that protection. So we all know this. I'm not going to go through that and why it's better. But I thought I would just do the last 3 slides here, which is a comparison now of the Affordable Care Act with what we want. So if you look at it, the core insurance system for the Affordable Care Act remains the for-profit private industry instead of a not-for-profit public insurance system. Coverage, really very incomplete here. Linked to employment, which makes no sense, persists. Underinsurance, widespread with the Affordable Care Act. Scope of service, as I mentioned, it's really kind of what's affordable. Whereas we believe that if you need the care, you should get it. And then I didn't mention, but dental, vision, and hearing is not covered except for peds. It's expensive. We all know the calculations that tell us that a single payer system would save us money, not cost us more. It's incredibly complex compared to a Medicare system, which is very simple, much lower insurance overhead. The individual financial responsibility remains premiums here, which even with the subsidized premiums remain really quite regressive compared to a tax, which would be more equitable, cost control. Very weak here, whereas with global budgets and bulk purchasing, we have pretty good cost control in Medicare for all. Total tort costs for medical care really weren't addressed here. They have some pilot projects they're suggesting, but no kind of major reform effort. And we know that tort costs are left with single payer because everybody's medical care is automatically covered and it doesn't have to be included in a malpractice suit settlement. So these is the suggested amount of savings of a federal single payer as estimated by Gerald Friedman. $476 billion in administrative costs, $116 in drug purchasing. And finally, in equity. Here, the competition is based on price. And with Medicare for all, I mean, if you provide good service, people are going to come to you. That's what's going to distinguish you, not because you offer the lowest price. They're going to come to you because you're good. So here the choice of provider is really restricted. And I just had this experience too, but I'll tell you about it next month. But anyway, here's a 2 or multi-tiered system, and what we want is an open, equal system for everybody. Here, we have no healthcare system, there's no resource management. Here, we would finally have a system, says what do we need, what communities, what's our expenditures be. And here we could they're trying to tweak the increase in the primary, increasing a little extra pay to the primary care providers, but that's only temporary, and some effort to increase the number of primary care providers coming out of medical school, but there's nothing to really assure you that they'll stay in primary care long term, because if they're not paid well, they will not stay there.
What are those
Whereas with
mathematical
Medicare
symbols?
for all, we could realign reimbursement to doctors so that people we'd get a better 50-50 division of doctors.
I think 1 degree means primary care. Was that one of them?
Well,
The arrow
it's-
Plus
throwing
minus.
The arrows
It
meaning plus or
said
minus.
plus or
Plus
minus
minus.
1%.
Your last
On the
slide.
last
What was
slide.
that?
Plus
The
or
last-
Last slide is in a
last-
plus minus.
You used a mathematical term, plus or minus 1%. As
The last,
Last slide.
last slide.
Which-
Last slide, last. Go, go.
I don't know which one it is.
The
There it is, that's
Oh,
it, that's it.
proportion of-
Plus minus just means more or less, jargon for more or less increased. Increased a little, marginally increased.
Oh, so it's not an actual number.
No. Yes,
I have a comment and I have a question.
yeah.
So my comment is, don't forget this, by removing the asset questions regarding the Medi-Cal expansion, that means that people will be entered into Medi-Cal that have assets, whereas
Correct.
before they didn't, or it was very limited. In California now, California made the decision that they're going to take back those assets after the person's death. So one of the certified enrollment counselors that we met with the other day said that with her very heavy accent, the people know they came to this country to buy a home so they could leave something to their children. They don't want the Medi-Cal. They want to pay for the insurance so they can leave something to their children so their children can have a better life. In other words, there is an issue regarding intergenerational wealth transfer that is intersecting with this insanity, okay? So this gets at the heart of some real social justice issues. Just wanted to make that point. And then my question to you, Nancy, is, first I want to say I am so totally impressed at how you put this together. It is awesome. And are you finding as you go and introduce this, or as you do a presentation on the Affordable Care Act and come in with your stealth bombs about single payer, are you finding receptivity in
Just
your
a little,
audiences?
not a lot.
Okay, that was what I was afraid of.
Yeah.
You're talking about primarily your physician audience.
Yeah.
So my guess is it's ideological objections. They're not able to comprehend the truth of what you're laying out because of their ideological objections to government. I mean, what do you think is the source of it?
variable. Well, I think I didn't go into it here, but I think because
Absorbent. They might go away and think about it. There might be a delay.
The other thing I was going to say, about the slide that I showed you, what were doctors' concerns? It's true, we're concerned that there's uninsured and that people get poor quality care, but their day-to-day practice, they're pissed off about the prior authorizations and the recertification and da-da-da-da, and those reporting forms. That's what they're mad about. And that's really not addressed. If anything, it's worse.
Yeah.
Because they're going to be forced to buy medical records they can't afford. Consequently, they're going to wind up joining large groups, becoming hospital employees. 25% are already hospital employees. 75% of residents who leave practice now are going to salaried positions.
Oh my God.
So, it's going to be this, they're sucking up. And the question that I have to ask, that I want to ask on Saturday, which I didn't go into here, when I say that it won't have an immediate impact on physicians, as I showed you, the profile of insurance hasn't changed that much, at least not immediately. So all those people who are out there in private practice, the American Medical Association, it's not going to be huge on them. But what will be huge is if Medicare starts pushing, and they are, and the hospitals are pushing it. The hospitals are buying practices, and they're shifting to a more capitated system. That's going to have a big impact. And so then the question is, now what we'll have kind of a capitated Kaiser system, but at the middle of it, there's a for-profit insurance company. And so what's that going to do to our single-payer movement? I've been trying to think it through.
So the hospitals are going to follow the Kaiser model, and large groups of hospitals can set up their own insurance plan that will advantage them.
I don't think so much that that's going to happen. It's that they are going to be contracting with insurance companies and Medicare.
But as a large group of hospitals, they
But the way
have
the
power.
contract is going to work is that we're going to capitate you on this life, insured life. We're not going to do a fee-for-service system anymore. So that's taking on risk. In order for them to be able to take on risk, it has to be a pretty significant organization. So it can't be just a bunch of doctors down the block.
Well, there are
It's
huge
got to be
groups of
big-time,
hospitals now.
sophisticated organization to become part of that. And because they built into this, both penalties and benefits in terms of if you meet certain criteria. If you don't meet the criteria, you start to get dinged 1-2% on your reimbursements. And over time that takes a hit. Whereas if you follow what they want you to do, you get 2-2.5% increase. and reimbursement. So there's a lot of push in this direction towards these big organizations because they're the only ones that are going to be able to pull off the kind of changes that are required in order to be eligible for those benefits.
This speaks a little to your point. I just read an article in the Washington Spectator. That's the group, it's the Clinton people, and they had a thing on Obamacare. And the takeaway was that what they're seeing nationally is more and more hospitals. Physicians are moving more and more into hospitals, but the
Right.
thing is that the hospitals are functioning basically as monopolies.
Yes.
In many areas, they're just one, you know.
Yes.
And then, now, where this leads, there's two quick things. First, they're projecting that the costs are going to go way up.
Exactly.
Whereas I think some of your slides were kind of, you know,
Yeah.
so they were explicitly saying that this is going to be, that the earlier rollout problems of Obamacare is minimal compared to what's happening with costs. And I'll end by saying I watched the Bill Maher program, and he has Republicans on. He has, and the one liberal was saying how all the good things about Obamacare, and the Republican said, "I'm really glad you said that. Because 2016, you're going to see the costs go through the roof, and you're going to own it. You Democrats are going to have to own the fact that Obamacare is sending the costs through the roof."
Yeah, I
So the
that's fair.
Republicans are, as usual, better organized, and they're ready to jump on this.
Yeah.
You know, so
I mean, as I said, it costs money. I mean, what are you going to do? You've got to pay for the Medicaid, you've got to pay for the subsidies, and that money's going to private insurance companies.
Well, what about Medicare Part D? The Republicans should own that. That's costing a fortune. too.
That's true, but this is also closing the donut hole of Medicare Part D, so we're using federal money again to pay pharmaceutical companies for their drugs.
Nancy, in a great presentation, by the way. I have a question about if we have these practices and we have the accountable care organization and you have capitation and you have this pay for performance gift, you know, however many percent, how are you going to sort that out? How will it be sorted out? We have a patient that has multiple problems, multiple diagnoses, several specialists. How is that going to work out?
It's worse than that, because the accountable care organization, first of all, the patient doesn't know they're in an accountable care organization. The federal government figures it out by seeing where they get most of their primary care. And if that physician is associated with an accountable care organization, then the patient is associated with the accountable care organization. The patient has no obligation to stay within the accountable care organization. If their organization is St. John's and they suddenly decide they want to go see someone or have their surgery at Cedars-Sinai, they're more than welcome. And St. John's Accountable Care Organization is responsible for that cost.
Oh, my God.
It's insane.
Oh, my
Yeah,
God.
insane is a good
It really is insane.
I-
There's no way that
I
was
mean,
said.
it
Could you
wasn't
re-
sad, it was funny.
All right, yeah. The question, I've heard that there, especially the public hospitals in Los Angeles County, that we're getting extra money from the federal government
Dish
because
payments.
of the
Mhm.
uninsured. What was it called? It was
Dish,
Dish.
disproportionate
a
share.
proportionate share. So I understand that that's no longer going to be given to them.
It's dramatically reduced.
And yet, at the same time, we have a very high percentage of uninsured,
Right.
which will remain uninsured.
Right.
And so the public hospital is going to be
In
taking care of
trouble.
them
Yes.
with less money.
Yeah. Now, I don't know the details on this one. I know that there's some wiggle room that they can readjust as they see how things are going, but I think they're starting out with like a 75% decline in dish payments. So depending upon where you are, some of these hospitals that, you know, have been very dependent on that are going to be really hurting.
Are these
Because
mostly
the assumption was, well,
public
now we'll
hospitals?
have all these people insured, so you're not going to need disproportionate
Yeah.
share anymore. That's a real problem, but I also suggested the Physicians for National Health Plan, we have a talk on how this is going to affect the, well, I think you said you were doing it here, the indigent community.
At some point we will. We've been attending, that seems to be the I say that the speakers of the moment are all talking about that, the indigent, the uninsured, the undocumented. This Tuesday night, Zocalo Plaza was talking about that. This last week when we went to the Churla and Immigration Policy Center, that's what they were talking about. At Labor United, that's what their speaker was talking about. So all of a sudden there's this light bulb going on that, oh, wait a minute, we have a big problem here.
Yeah.
Yeah.
Well, and of course, we have a primary care problem, too.
Yes.
There was just a survey that came out this week in the Journal of the American Medical Association where somebody pretended that they needed primary care services, and they said, either private insurance or Medicaid or whatever. And they had no trouble getting an appointment if they had standard commercial insurance, but if they had Medicaid or exchange insurance, they had a little trouble getting an appointment.
But even that can be a problem, because Georgia had a story about a friend of hers in Santa Barbara, which is,
Well, this is a
Shocking.
client of Shannon Miller, who is the executive director of Healthcare for All, the state. And she happens to be a CPA or certified, anyway, something to do with taxes and accounting and stuff. And so she had a client that was unable to get insurance because she had a pre-existing condition. And that pre-existing condition was like a gynecologic type of a problem. And so she just had to go without treatment for all these years, and suddenly here comes Obamacare. Oh wow, so she's so excited, and she tries to sign up on the exchange. Well, her income is too low, and because of the Medi-Cal expansion, she was eligible for that. Great, she can finally go to the doctor. She finds there are 3 gynecologists in Santa Barbara County. None of them are accepting new patients.
Right.
Of course,
Certainly not Medicaid,
not Medicaid.
not if you can afford to live in Santa Barbara.
Yeah.
There are a lot of poor people there. It's just the hidden poverty, I guess.
I wanted to comment on the future politics of this.
Yeah, please.
I think the Republicans are going to stop talking about repealing Obamacare. That'll happen sometime after the November election. And they're going to come up with fixes which will involve spending less government money and individual people spending more money.
Yes.
I was thinking, based on what you presented, there are some specific improvements in the ACA that we could advocate. The most obvious to me is requiring that all states have the same level of Medicaid.
Yes.
That would be a huge difference, so Alabama can't cheat the rest of, their poor.
Right.
And another one, I noticed there are about 10 different taxes involved in the ACA.
A lot.
And the one I didn't see there was a tax on the rich and the corporations. So if you eliminated all those taxes, the money could come from the income tax, the corporate tax. And that could be part of our
Yeah.
suggested,
You
when
know-
we talk to legislatures, first of all, we have to elect Democrats to Congress. When we talk to them, we say, in order to be a good congressperson, this is what you should advocate for, this is what we want. And the other one that I think we could suggest is if there are less than 5 insurance companies in a state, individuals should be able to get their insurance in another state. That is feasible, I think. That's a
The
logical.
Republicans like that, the crossing the state
Yeah.
lines.
But it doesn't make sense to limit people to one insurance company, and that can
Well,
be fixed. In fact, you
unfortunately,
can
what
get the
they
Republicans to
wanted to
vote
do,
for
some
it.
states have very crappy insurance policies that they don't regulate them very well. And so if people were able to cross state lines, they would, it would be a race to the
They
bottom.
would all buy
basically.
California policies, right?
But in terms of these taxes, like one, I didn't go to the details, but there's a tax, increased tax, Medicare tax, Part A Medicare tax to fund this plan of 0.9% for people over $250,000 income. And there's also a tax on,
That's worth
it's
fighting for.
unearned income. And anyways, you asked about what people ask about, would you believe the last time I gave a talk, this guy comes up to me after the talk, and his concern was he was a general surgeon. He was annoyed. His income was $1.5 million, and he didn't like the fact that he was having to pay another 0.9%.
That's a big theme in politics now, sympathy for the rich.
Of course.
And this, this business about this guy in Florida making $26 million in ophthalmology, what's going on?
Yeah.
I mean,
The
in a way,
hemocs and the ophthalmologists.
and what-
Hemocs and ophthalmologists.
I could understand some of the explanations that were given, like the hem-onc people buy their drugs and sell the drugs back, and they're very expensive drugs, but still.
Kind of linking on to what Lee was saying, we may actually have partners that will surprise us in the move towards increasing Medicaid in other states, because uninsured people cost money.
Exactly.
They cost the hospitals money, and they cost the counties money, and they cost the state money. And I believe it's something like $1.3 billion that uninsured people cost in ER. So these states that have not accepted this federal money and have not expanded Medicaid, we may see a move just because the for-profit institutions and also the state are having to pay out of
You're
pocket.
absolutely right, but it's been calculated that the states that turn down Medicaid are going to wind up paying more out of their state budgets to take care of these uninsured people than they would have had they expanded the Medicaid. But it's just, meanness in politics.
It's politics.
I think-
Politics is the art of making the possible impossible. Somebody else said it.
There's a-
Pass it on.
There's a bill we should support in the Senate now, it's SB 1005, I think, it's Ricardo Lara from Long Beach. And the bill will open up health care to all of the undocumented people.
Oh, yes.
And of course, that will change the way they get health care. They'll get preventive care, through LA Cares, which is a pretty good organization. It's like HMO for the poor. And they'll need less emergency care. And all in all, it won't be as costly as people imagine. It could save money in many ways. So if we can adopt or support a particular bill, that's the one I think we could start with.
Well, thank you very much.
Thank you.
Yes.
Is this going to be
Thank
up on
you,
the
everybody.
PNHP website, Nancy? No.
Well, Charles here has been